My name is Dr. Kunal Parwani and I am an assistant professor in cardiology department at UNMICRC Institute of Cardiology and Research Center. Today I am going to talk about the transseptal puncture. The outline of my presentation is going to be first I am going to introduce you to the transseptal puncture. I am going to mention the indications, the contraindications, the technique to perform the transseptal puncture, the difficult situations like accessing the huge RA or huge LA, engaging fossa ovalis, needle advancement, and sheath and guide advancement. And then lastly, we are going to talk about the complications and management of the transseptal puncture. Transseptal puncture is essential step in performing a very important procedure called the balloon mitral valvotomy through the antegrade route, which is the most commonly utilized technique. And the knowledge of the anatomy of the interatrial septum is very important in making a safe transseptal puncture. In mitral stenosis, the left atrium and many a times the right atrium are hugely dilated, distorting the anatomy. And occasionally the patient might have undergone closed mitral valvotomy and LA appendage excision so as to distorting the anatomy, and these all can bring about challenges in performing a safe transseptal puncture. The transseptal puncture was developed by Ross, Braunwald and Morrow at the National Heart Institute, now called the National Heart, Lung and Blood Institute, Bethesda, in 1950s to allow the left heart catheterization, principally for the evaluation of the valvular heart disease. Important refinements were made to the needle and catheter such that the Brockenborough description of the technique in 1962 differs little from that used now. Mullins developed a combined catheter and dilator set designed precisely to fit over the Brockenborough needle, which gives a smooth taper from the tip of the needle over the dilator and helps us in performing a safe transseptal puncture. So before performing a safe transseptal puncture, it is very important to know the proper anatomy of the fossa ovalis. The interatrial septum is bounded posteriorly by a fold of the pericardium between the LA and the RA, superiorly by the SVC and anterosuperiorly by the non-coronary sinus of Valsalva of the aortic valve. Anteriorly it is bound by the tricuspid annulus, and antero-inferiorly it is bound by the coronary sinus os, and inferiorly by the IVC, as you can see in this picture. The fossa ovalis is the true interatrial portion of the septum, and typically it is the thinnest portion. It is considered the safe place to create a puncture for entry into the LA. The limbus of the fossa ovalis is pronounced antero-superior margin of the fossa ovalis within the right side of the interatrial septum. It represents the inferior margin of the septum secundum during the fetal life. The fossa ovalis appears as a depression in the interatrial septum when viewed from the RA side. The fossa ovalis is surrounded by the muscular septum, the thick portion of the septum secundum and the primum. The fossa ovalis is either oval or it is circular, and usually averagely it varies from 1.5 to 2.4 centimeter in the adult, and it is located posteriorly at the junction of the mid and the lower third of the RA. Talking about the indications for transseptal puncture, the indications are numerous, but the main ones are the LA and LV hemodynamic assessment, diagnostic EP study for the LA and LV arrhythmia, and it is also used in the therapeutic procedures like balloon mitral valvotomy, pulmonary vein isolation and pulmonary vein balloon dilatation, LA appendage closure, LV assist devices, paravalvular leak repair, mitra clip, mitral valve-in-valve procedure, and TMVR, that is transmitral valve replacement. This slide shows the evolution of the indications for transseptal catheterization. As you can see, first of all, it was used for the hemodynamic assessment, and then for the PTMC, and then it was used for the pulmonary vein isolation procedures, and then eventually it was used for the mitra clip, and then for the TMVR as the time evolved. The contraindications of the transseptal puncture, the absolute and the main contraindication for the transseptal puncture is a thrombus in the LA. Why? Because sometimes we might do, in doing transseptal puncture, we might dislodge the thrombus and it can lead to the grave consequences. Other contraindications like distorted anatomy, huge LA or RA, aortic root aneurysm, interrupted IVC, they all can be tackled by one or the other techniques. But thrombus in the LA can lead to grave consequences. For the safe transseptal puncture, we need to be well versed with the three things. First is the hardware, second is anatomic landmarks, and third is the imaging guidance. About hardware, there are two most important hardwares that we use in the transseptal puncture. This catheter, as you can see in this image, is a Mullin's dilator and sheath catheter. This catheter has 270-degree curve at the end that is straightened by the dilator, and it is most widely known as a Mullin's catheter. It is developed by the Medtronic industry. The radius of the end of the catheter is available in different sizes, allowing variable reach within the RA. As you can see in this table, the adult sheath length is 59 cm and the dilator length would be 67 cm, and the wire that it will take will be 032 inch. This is most commonly used in the adult. And in the downward images, you can see the Mullin catheter with the needle inside the Mullin catheter. Second is this needle that is most important in this procedure. This needle most commonly used is broken borough needle by Medtronic. This needle is an 18 gauge hollow tube that tapers distally to the 21 gauge. The proximal end has a flange with an arrow that points to the position of the needle tip, as you can see in this picture. It behaves as an indicator and guides us where the needle tip would be. There are other, St. Jude has also come up with the BRK needles that has 19-degree angle between the distal curved segment and the needle shaft, as you can see in the right uppermost corner of the image. BRK1 needle has 53-degree angle and it is ideal for the patients with the dilated RA. And the needle is available in two lengths, that is 71 cm or 89 cm. Septal puncture can be done by using Mullin dilator alone, but often it is used with a dilator sheath assembly together. This is the indicator that is available with the broken borough needle. It helps us in knowing where the needle tip would be. As you can see, it can rotate 360 degree in a clockwise anti-clockwise direction, and it helps us to make a safe transseptal puncture. Now we will talk about the important anatomical landmarks that will guide us in doing a safe transseptal puncture. As you can see here in this image, if your broken borough needle would be in RA, and if you rotate it in clockwise direction, you can see from 3 o'clock to the 7 o'clock position, you will face the interatrial septum here. This is a fluoroscopic image of the AP view and lateral view, and as you can see in the AP view, our fossa ovalis would be lying lateral and inferiorly, that is the posterior-inferior position. As you can see in the first image, you can see the RA getting opacified, you can see the aortic root. In the second image, you can see the LA lateral wall and the aortic root. And in the third image, you can see both RA and LA overlapping each other, and you can also appreciate the interatrial septum and where our needle would be. In the lateral images, you can see in the first image, you are seeing the opacification of the RA and the RV. In the second image, there is LA opacification and you can appreciate the interatrial septum. And at the third image, you can see where our puncture needle should be. In RAO view will enable us to divide the septum into anterior and posterior planes and it will allow the assessment of the relative anterior and posterior location of the fossa ovalis. Here you can see the AP view. In the AP view, you can see the fossa ovalis is lying posteriorly and slightly inferior to the aortic root. This is the lateral view and you can appreciate the position of the fossa ovalis in comparison to the aortic non-coronary cusp, aortic sinus. You can appreciate that it is lying behind the posterior location and slightly below. And this is the LAO view. Placing the fluoroscopy unit in the LAO position between 30 to 45 degree will provide a perpendicular view of the interatrial septum. In this plane, the transseptal axis, that is their needle, will appear in full profile when the tip is perpendicular to the septum. Now talking about the procedure, which is the most important step of the transseptal puncture. First we take the femoral approach. We place the 8F sheath in the vein and 6F sheath in the artery. And right heart catheterization is performed. Pigtail is placed in the aortic root and sheath assembly. You have to prepare the sheath assembly on the table and check the needle compatibility with the sheath. Procedure I'll describe one by one. So the first step that we do is we place the pigtail in the non-coronary cusp of the aortic sinus. Secondly, we have to advance the O32 wire, that is the exchange length wire 300 cm in length, in the left innominate vein. The exchange length wire will enable us the easy introduction of the Mullin dilator over the wire. Second step would be advancement of the Mullin sheath and dilator. The Mullin sheath and dilator is introduced over the exchange wire and placed in the innominate vein over the exchange length wire. Before introducing the Mullin sheath and dilator, you have to check the length of the sheath and dilator and its compatibility with the needle on table. You have to tally that before selecting the sheath. After placing the Mullin sheath in the innominate vein, remove the exchange length wire, leaving the Mullin sheath and dilator in the innominate vein. Third step is introduction of the broken boro needle and making the sheath needle assembly. Here, the first step in the septal puncture, safe septal puncture, the most important is the formation of the needle sheath assembly. And for that, the Mullin sheath and dilator and the broken boro needle is used. First, the length of the dilator in relation to the needle is checked. Ideally, and it has to be done on table before introducing it inside the heart. Ideally, the needle should protrude 3 to 5 mm from the tip of the dilator. Once this is confirmed, the broken boro needle attached with a 3-way stopcock and a syringe filled with saline is introduced through the Mullin sheath and dilator. It is better to flush the saline continuously while the needle is being introduced, as it will smoothen the passage of the needle. In this image, you can see the needle should be parked more than 1 cm, that is by using index finger and the middle finger proximal to the tip of the Mullin sheath. The operator should fix his right index finger between the catheter hub and the indicator of the broken boro needle to prevent the needle from moving forward and protruding from the catheter tip. Usually the direction indicator of the needle is kept between 4 and 7 o'clock position. The thumb and the middle finger should maintain the direction of the needle so that its direction and position is not changed. Once the needle is in place, the saline is disconnected and a 3-way stopcock is connected to the diluted contrast, that is 1:4 dilution, and few ml of contrast is injected through the needle to confirm the flow. Next step is the descent from the SVC to the RA and to the RA fossa. This is done ideally in the LAO view where the septum is vertical or in the AP view. Keep the pointer in the septal puncture needle pointing between 3 o'clock to 5 o'clock position when viewed from the foot end of the patient. This should put the distal curve of the sheath, dilator and needle perpendicular to the interatrial septum. Once more confirm that the needle is well inside the dilator by fluoroscopy. Then drag the entire sheath and dilator needle assembly slowly downward from the SVC to the RA. Be careful so that the component of the assembly is not rotating or changing their relative positions to each other. In the LO view or AP view, while descending, observe the tip of the dilator during the drag for any abrupt medial movement. The first movement that you will appreciate will be that the catheter falling into the RA from the SVC, and then there will be a second more subtle movement as the catheter falls over the limbic region of the fossa ovalis. Sometimes the catheter might fall more anteriorly or antero-inferiorly and enter into the coronary sinus, and that you have to confirm by seeing other views as well. Checking the RAO and lateral view will help assess the antero-posterior location of the assembly. After we enter into the RA, in the AP view, the transseptal puncture is usually done under fluoroscopic guidance, and there are certain fluoroscopic landmarks which are used to identify the location of the fossa ovalis, where we usually puncture the septum. The pigtail catheter marks the location of the aortic valve, the non-coronary cusp, that is the lowermost cusp of the aortic valve. In the AP view, the tip of the transseptal dilator engages the fossa ovalis inferiorly and medially to the aortic valve. So to determine the location, you have to draw a horizontal line from the pigtail catheter towards the lateral border of the RA. At the midpoint of this horizontal line, draw a vertical line, and about one vertebra lower to this horizontal line will be the site of the fossa ovalis. As you can see in this image, a horizontal line is drawn from the pigtail to the lateral end of the RA, and at the midpoint of this horizontal line, just one vertebrae below the space would be the ideal location for the puncture. But this has to be confirmed in other views like lateral view and RAO view as well. In this fluoroscopic image, at the left hand side you can see the AP view, and as I have already described, there is a red horizontal line being drawn from the pigtail catheter to the lateral wall of the RA, and at the midpoint of this horizontal line a vertical line is drawn, and at the interjection, from the interjection point, one vertebrae below space would be the ideal site of the location of the transseptal puncture. This you have to check in the LO and lateral view as well. Other views are very important in checking this thing. In the right hand side of the image, that is the lateral view, you can see a pigtail catheter. From that pigtail catheter, you have to draw a line towards the spine of the patient, and if you divide that line into three segments, the middle 1/3 segment would be the ideal site of the septal puncture, and the dilator should be pointing to that middle 1/3 of the line. In the RAO view, for this view you will need the LV angiogram. Usually this is not done, but this can be helpful in performing the safe transseptal puncture by obtaining a LV angiogram and a diastolic still frame. You can see here, you can appreciate the mitral annulus. From the midpoint of the line of the mitral annulus, we draw a horizontal line, and at the midpoint of this horizontal line, that is called the M line, about one vertebra below space would be the ideal site of the location of the transseptal puncture. These all line and everything that we have to make a mental picture of it, and with the repeated practice we will be able to do the transseptal puncture efficiently and quickly. Now what we practice is the needle will be maintained in the correct orientation as far as possible during the descent. We don't have to change the needle orientation. The needle position will be checked and altered in the RAO view and lateral view. If the needle position is altered, then it is checked in all the three views, that is the RAO, AP and lateral view. We may have to adjust and orient the needle, especially in the case of the large RA. You can see in the image from 2 to 7 o'clock position, we are facing, our needle will be facing the interatrial septum. And At the 4 o'clock to 6 o'clock position, we will be facing the normal fossa ovalis plane. This is the indicator that is available with on our broken burrow needle, and we have to face the indicator at 4 to 6 o'clock position to face the fossa ovalis. In this slide you can see, if there is a huge LA with a bulging septum, the fossa ovalis is shifted inferiorly and posteriorly, and then the indicator has to be placed at 7 o'clock or even 8 o'clock position. If the LA is too small with the invert septum, we have to bring our indicator to the 3 to 4 o'clock position. Use of the transesophageal echo comes very useful and very helpful in performing a safe transseptal puncture. Wherever available, transesophageal echo should be used, and the position of the needle should be confirmed in bicaval 90-degree view as well as the short axis 45-degree view. These two views are very important, very crucial in performing the transseptal puncture. The next step would be engaging the needle in the correct position and flush the contrast and stain the septum. If the needle is snugly fitting the septum, we will not be able to flush the septum, but the septum gets stained. Staining the septum is of no major consequences, except that it can produce some ectopics rarely. Staining will give us the idea about the site of the puncture. A vertical stain indicates that we are parallel to the septum, and it usually indicates the dissection. We require a more horizontal stain, and a horizontal stain is better. If the puncture site is too low, then the needle is if the puncture site is too low, it might produce a more horizontal septal stain. So after obtaining a septal staining, the next step is puncturing the fossa ovalis. Now we do the puncture in the lateral view. Many groups do it in the AP, RAO or LAO view, but it is better to do in the lateral view. It depends on the operator. If we are not able to engage the needle in appropriate puncture site, usually the needle is removed and a fresh attempt is made by taking the mulin directly to the innominate vein and restarting the whole procedure. The puncture, this is abrupt jerking the needle forward inside the mulin. Sheath is maintained in the direction of the needle using the right hand and holding and fixing the sheath with the left hand. This should be observed in the fluoroscopy. As you can see in this, the broken burrow needle is advanced over the mulin sheath, and there will be a jerking motion, and that will indicate a puncture. It is more of like a feeling of a giveaway. This should be done under the fluoroscopic guidance. If the needle is connected to the pressure transducer, when the puncture is made, there is a sudden elevation of the pressure as the needle passes in the left atrium. Once the left atrial entry via the fossa ovalis is confirmed, advance the sheath and dilator assembly over the needle. It is advised to keep the needle at the fixed position. And once you enter into the LA, it is better to give the puffs of the contrast to confirm the position of the needle, that whether we are in the LA or not. Then the needle is removed and LA wire and the LA wire is entered through the mulin sheath and dilator into the LA. There are certain things to confirm that our needle is in LA or not. One is definitely the fluoroscopic image. Then there is withdrawal of the oxygenated blood, the contrast injection, and the LA pressure. These steps would help us to confirm that we are into the LA. Talking about special situations, sometimes you might land up in a situation where there is enlarged LA. In those cases, you have to point the indicator more clockwise That is, you have to point the indicator at 6 o'clock or 7 o'clock position. Sometimes the RA would be enlarged, and in those cases you have to bend the needle more, you have to make the angle more acute. Sometimes we'll end up in the situation where there is a prior septal occluder, okay, and one may do the septal puncture posterior inferior to the device. If that is not possible, then we have to puncture the device itself, and that is achieved by using 014 coronary wire that is parked in the LUPV and a serial dilatation with 2.5 or 4 millimeter of NC balloons. These are the indications, various indications and various sites of the transseptal puncture that can be of use. As you can see in this, for the various positions of the fossa ovalis and the location of the transseptal puncture required to perform those procedures. Talking about the complication of the transseptal puncture, the most common complication is cardiac perforation and tamponade. The incidence is less than 1% in diagnostic hemodynamic studies, 1 to 2% in performing the BMV, and 2 to 3% in performing pulmonary vein isolation and LA appendage closure. Second is thromboembolism. Highest is with the pulmonary vein isolation, 5%. Third is air embolism. Occasionally, iatrogenic ASD is also created. Hemopericardium and tamponade. The rapidity and the extent to which the effusion will develop will depend on the needle, the dilator, the sheath, catheter, the anticoagulation used. The risk factors are small LA cavity, thick and resistant septum, floppy septum, excessive catheter manipulation. And in case of the hemopericardium or tamponade, we may have to do pericardiocentesis, and sometimes it may require surgery as well. Second most common complication is stitch phenomena. As you can see in this image, if the needle perforates the junction of the RA and LA more posteriorly, it might travel from the RA to the pericardium and enter into the LA, leading to effusion, and this is known as stitch phenomenon. It is suspected in fluoroscopy by usually low or high posterior puncture. Still, the patient may remain hemodynamically stable, and unless the catheter or the sheath is withdrawn, patient might be totally hemodynamically stable. If one recognizes the stitch puncture during the intervention, one may complete the intended procedure if feasible. At the end of the intervention, without losing the left atrial access, the atrial septal occluding device can be used to close the perforation. And sometimes you can keep the sheath in the LA and send the patient for the surgery. It may be a good practice to keep the guide wire in the LA. This animation shows the stitch phenomena while performing the BMV. Think before pulling out. After the septal puncture, always wait for 2 minutes. Watch hemodynamics, watch for echo, and then give the heparin. Management of the stitch or effusion, we have already discussed. Only a needle puncture. If only a needle puncture is made, then you can defer the procedure, wait and watch, repeat echo at regular interval. If the balloon has been advanced, you may complete the procedure of the BMV if the patient is hemodynamically stable. And if the septum is dilated, don't remove the dilator. Keep the pigtail in C2 and shift the patient to the CVTS with the dilator in C2. Reverse the heparin with the protamine, and also you can do auto transfusions. Aortic root staining. If this happens, then we have to abandon the procedure, observe for the hemodynamics, effusion. If only a needle puncture is made, then wait and watch and defer the procedure. Sometimes inadvertent aortic puncture is made. Confirm this by aortic pressure trace and contrast. If needle is entered, withdraw the needle. If sheath is introduced, then patient will develop rapid tamponade on removal of the sheath. In those cases, you don't have to remove the sheath. Keep the sheath in the same position and send for the surgery. Sometimes implantar vascular device closures are used to close the malhappening. In conclusion, for performing a safe transseptal puncture, it is better to understand the anatomy, know the fluoroscopic landmarks, use transesophageal echo wherever possible, be prepared to deal with any challenging anatomy, be ready to handle any complications. Thank you for listening me.